All right. I want to be mindful of everybody's time here. So I do have the top of the hour, and I will go ahead and get started as people are trickling in. So hello, everyone, and good morning. Welcome to the first session of the DRCHSD program Community Paramedicine Technical Assistance Opportunity webinar. Go ahead to the next one. So the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the nation's leading technical assistance and knowledge center in rural health. The center has served rural healthcare organizations and partnered with FRHP for nearly 25 years and collaborated with the Delta Regional Authority for 15 years to assist rural providers and communities with their healthcare needs. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about what we're doing with DEI work on our website. With the support of the Delta Regional Authority and the Health Resources Services Administration's Federal Office of Rural Health Policy, the center administers the Delta Region Community Health Systems Development Program and manages the provisions of services to selected healthcare organizations and communities over a multi-year program period to make in-depth health system enhancements to position the organizations and communities for population health. Now I'll be turning it over to Karen Lund. She's a senior program specialist that has worked with the DRCHSD program for nearly 3.5 years with the Community Care Coordination Team. She will serve as the lead for Community Paramedicine technical assistance moving forward. Karen?
Thanks, Caleb. Today, I want to spend our time establishing some foundational knowledge on community paramedicine for the organizations that are already considering implementing CP programs and those just getting started learning more about this topic. During our webinar today, we will highlight the current healthcare transformation landscape we're working in, distinguish some terms common in the CP space, share services typical of these programs, hear from panelists that have implemented community paramedicine programs, briefly share our framework, and take some time for questions. We encourage your questions today, so please utilize the chat box on the bottom left-hand side of your screen. Before I jump right into community paramedicine, I want to share the DRCHSD program purpose and goals for individuals just joining a webinar with us for the first time. This program has been assisting healthcare organizations and communities since 2017 to develop and sustain local system of care. Services are provided through technical assistance, which includes various assessments and consultations, action planning, and coaching implementation of best practices that work to increase care coordination, improve the quality of care and patient experience, build awareness of local services, reducing bypass, enhancing partnerships and collaborative relationships, increasing the long-term viability of the organizations, all to sustain a local system of care to prepare organizations and communities for population health. All of these program goals shown tie directly to our newest technical assistance area, community paramedicine, which we see as further enhancing care coordinations in the communities that we serve. Here at the beginning, I want you to notice the similarities between the triple aim on the left, Healthcare 3.0, and EMS 3.0. Most of you are already familiar with the impact that the Institute for Healthcare Improvement's triple aim has had on moving the healthcare industry and our work towards improving quality of care, optimizing costs, and simultaneously improving the health of the population. I want us to also look back because the US healthcare delivery system has evolved drastically over the course of even our lives. Sometimes we refer to these evolving landscapes of healthcare as Healthcare 1.0, 2.0, and now 3.0. If those are new terms for you, I want to take you back a bit. Healthcare 1.0 is defined as a time where physicians worked in smaller practices. Doctor-centered care with little regard for patient experience was our norm, and providers dictated treatments and billed using fee-for-service-based systems. Healthcare 2.0 saw hospital systems growing, big pharma thriving, disease management focused, fee-for-service driving volumes, and the growth of technology. To some, it could resemble an assembly line with fixed protocols and medications for every disease, where patients didn't really ask questions. In Healthcare 3.0, we saw a shift to patient-centered, high-quality, technology leverage, patient evidence-based care with intent on addressing root causes for diseases, prevention, and reducing cost per capita by focusing on keeping people healthy. While at the same time all of this has taken place in the healthcare industry in the US, EMS has been transitioning as well. In the mid-1990s, EMS started taking a critical look at the future, and in 2004, they published Rural and Frontier Emergency Medical Services Agenda for the Future, which called on EMS to add value by integrating with the healthcare system to offer community-based health management, treatment for chronic conditions, and injury care follow-up. In the early 2000s, the establishment of the first community paramedicine programs began to see that vision realized. And now we see EMS 3.0 as an EMS industry initiative to help agencies and practitioners understand the changes that are needed in EMS to fully support the transformation of our nation's healthcare system, and to provide tools and resources to help implement these changes. EMS 3.0 highlights how our nation's healthcare system is transitioning from volume to value, and how EMS agencies can stay ahead of the evolving landscape. I want to emphasize that agencies will still provide core EMS capabilities, such as 24/7 911 dispatch, rapid assessment and treatment, and emergency transport, while also expanding into nurse advice, post-discharge follow-up, preventive care, chronic disease management support, and alternative transportation and referral, which add value and ensure that the right care is delivered at the right place and at the right time. As this landscape continues to evolve, you may more frequently hear these terms: mobile integrated healthcare and community paramedicine. While they are both patient-centered mobile services offered outside of medical facilities, there are some distinctions that may be helpful for our team and organizations to understand. Mobile integrated healthcare is an administrative organization of multidisciplinary medical, nursing, and other practitioners, which may or may not involve EMS paramedicine providers. On the other hand, community paramedicine, which you are going to hear us refer to for this technical assistance, is an extension of EMS paramedicine practice and services that allow paramedics and EMTs an expanded role by assisting with public health and primary health care to cover healthcare gaps in communities. Today, hundreds of EMS agencies across the nation of all sizes and types are partnering with hospitals, primary care physicians, nurses, mental health, and social service providers on innovative programs that navigate patients to the right level of care, with the overall goal of lowering costs, improving care, and enabling EMS practitioners, which includes EMTs, paramedics, and community paramedics, to use their skills and resources to help solve the problems facing healthcare systems and communities. A question that people often ask is, how is community paramedicine different than traditional EMS? The short answer is that community paramedics provide enhanced care coordination, case management, and healthcare delivery of non-emergent services. Here are just some examples of services provided by community paramedicine programs. This list is certainly not all-inclusive, but should give you some examples of what service line offerings may consist of. As you can see, there's tremendous value added from the EMS working more closely with healthcare organizations to address the unique population health needs through community paramedicine programs. So what do successful community programs for community paramedicine look like across the country? That answer largely depends on the specific needs and resources available to support these programs in the communities they're in. Next, we're going to hear from two panelists that have implemented community paramedicine in their communities. Paul Miller, Division Chief of EMS, Crawfordsville, Indiana, Community Paramedicine Program, and Richard Bell, Operations Director with Acadian Health out of Louisiana. Again, I want to remind you that we encourage questions. So please utilize the chat box feature at the bottom left-hand side of your screen if some questions come to mind as these speakers are talking. Let's start with Richard. Please tell us why you decided to implement community paramedicine in your community.
Yeah, thank you, Karen. Thank you for the opportunity to talk to the group today. As Karen said, please ask questions. My time is yours, and I'm passionate about this topic, and I want to make sure that I give you all the answers that I possibly can. So we started looking at this concept 11 years ago now, when we recognized that we had frequent, what we call our loyalty customer program, I guess you could say. We had frequent utilizers of emergency services in various coverage areas across our 911 coverage. And these people were frequently calling us, and we were going to the homes and transporting them, but they kept calling us, right? Chief Miller probably understands exactly what I'm talking about. You have people that, for whatever reason, they just can't seem to manage their medical conditions appropriately, and they're frequently utilizing emergency services and ending up in emergency departments. And everybody that's on here that's hospital-based understands what the trickle-down effect of that is. So we kind of took it upon ourselves to say, well, let's spend a little bit of time here and go out into the community and sit down and meet with these people to see if we can identify what the root cause of the problem is. So that's what we started doing. We started doing this initially just to be able to utilize our resources, our 911 resources, more efficiently, because they were being utilized for these repeat customers. So the idea is if we can plug these people that are frequent utilizers of the system into the resources that they need so they can better manage their own health, then they're not going to call us as often, and those resources are going to be available for more acute calls or more acute emergencies in the communities. So that was how we first entered into the whole concept of community paramedicine. And then when we started having conversations with ACOs and with the payers about what we were doing and what we found, the payers started coming to us and say, well, look, we have all this data on high utilizer populations ourselves. So can you do the same thing for our members that we refer to you? So that just kind of opened the door to looking outside of our organization to see how we could help other organizations address the same thing. And since then, we've expanded our community paramedicine programs. We're now operating in 3 states, and we're looking for significant expansion throughout the course of this year.
Thanks, Richard. Paul, I'm wondering if you can also speak to the same thing. Why did you get started implementing a community paramedicine program?
Pretty similar story. I mean, obviously, excuse me, it's the right thing to do. That's what the fire department's expected to do, much like fire prevention, EMS prevention kind of fell right into this category pretty easy. But the other side of it is it's really about economic development too, and better sustaining our rural health partners in our area. What's good for them is good for us. And this really does do a lot to drive economic development. Since we started this in a similar time frame, we've seen about 130 rural health hospitals close. In our own community, we've seen OB units shut. So we were losing services and creating OB deserts and healthcare deserts in our rural community. So we wanted to be a better healthcare partner. And much like other organizations, once you start meeting with payer sources and ACOs, you see how we're speaking the same language in different terms, but we still want to reach the same goal and provide better patient care experiences and better healthcare outcomes. So that's kind of how we initially started and moving forward into multiple promising practices with the State Department of Health and other healthcare leaders.
Thanks, Paul. We had a question in the chat for Richard. Which 3 states?
Currently, we're operating in Louisiana, Texas, and Tennessee.
Thank you. Do you want to just give the group an idea of what your service area looks like?
Acadian Ambulance is obviously our ambulance division, and we operate in Tennessee, in Memphis, and in Nashville. We're also in Mississippi, specifically in Jackson County, which is directly across the Alabama line from Mobile. Louisiana, we cover over 60% of the state of Louisiana and provide 911 coverage for over 60%. And then in Texas, we're in every major metro area. We're in the Dallas-Fort Worth area, Austin, San Antonio, Houston, and further southeast Texas into the Beaumont region.
Thank you. Paul, do you want to talk about your service area as well?
A little bit easier and not as large. So we're a small rural community. So we deliver 911 services to our entire county, which represents about 40,000 people roughly. And we deal predominantly with one hospital.
Thank you.
And just to add to that too, Karen, I say that, we're in all the major metro areas in Texas, and we're obviously in the major metro areas in Tennessee and Louisiana too. But I will say that the bulk of the coverage area that we provide 911 services for, and we're also providing community paramedicine program coverage for, are in the rural or the suburban and rural communities that also surround those metro areas. For instance, San Antonio Fire Department, they handle incorporated Bexar County in Texas, but we cover unincorporated. So inside the city, it's fire-based EMS. Outside of the city, going into the rural communities, that's our coverage area.
Thank you. So it was intentional that we have one Delta state represented here and one non-Delta area, Chief Miller. We also have rural represented and we have urban represented. So hopefully you all can get a good grasp of what this could look like in your unique area as well. Next, I think we're going to start with Richard, and I'd like you to talk about some of the big wins that you've had since implementing community paramedicine.
Sure, and it's actually, it goes back to the first ACO group that we decided to start working with. This is it's an ACO. They have 5 locations in and around the greater New Orleans, Louisiana market, and they're fully at risk for a population of Medicare Advantage members. And they had high utilization, right? They had the patients that were calling 911, and they had the patients that were being readmitted into the hospitals. So they came to us and said, what can you guys do to help us with this population of patients? So as proof of concept, we said, okay, well, we want your highest utilizer, your most difficult patient, and we'll take that patient on free of charge, and let's see what kind of impact we can make in this patient's life. And this was an elderly female. She was diabetic, and she also had CHF and COPD. So she had the triple threat, right? She had everything going on. But what we found out, and what we've consistently found out working with patients, is most of what we do is not clinical. Most of what we do with these populations is social. Heavy emphasis on social determinants of health, especially when you get into the rural communities. Like Chief Miller said, a lot of these rural communities, they're losing resources. So when these resources are lost and you're dealing with somebody that has transportation challenges or mobility challenges, they don't have resources in their community. So how are they going to get to these resources outside of their community when they already have these challenges that they're facing? So we started working with this lady, and we were able to turn her situation around by plugging her into social services that were available in the community that she lived. And her life changed, her lifestyle changed, her quality of life increased. And that was a really good win for us early on. And since then, that customer is still they're our flagship customer. They're our biggest account. And out of the 5 clinics that we work with in the New Orleans metro area, when they call us to go manage a patient's condition in the home, or they call us to go into the home to assess a patient, to see what's going on with them in hopes that we can manage them right there on scene and leave them at home, as opposed to bringing them to the clinic or bringing them or referring them to the emergency department, 96% of the time we're able to effectively manage that patient in the home. Now, I will say that that is attributed to the engagement or the level of engagement of the physicians in that ACO, because the physicians refer the patients to us. We don't take calls directly from patients. we take referrals from physicians because they're not our patients. They're the physician's patients. We're just the eyes and the ears and the hands in the field. We're the physician extenders, right? So when that physician calls us, we go to the home. 96% of the time, we're able to manage those patients. And the other 4% of the time, they either end up in the emergency department, and of the patients that do end up in the emergency department, is 100% admission rate, which just justifies the fact that they got to the emergency department, which was the appropriate place for them to be. In the other 2%, we transport that patient either to the clinic, or we arrange for public transportation or an Uber or a Lyft or something like that to get the patient to the clinic where they can see their doctor. So I would say that first lady, she was the biggest win that we had, because that lady, like I said, her quality of life improved drastically. So the last several years of her life were totally different than they would have been had we not enrolled her into this program.
Thank you. Paul, how about you? What are some of the biggest wins that you've had since implementing?
So multiple, and I kind of quickly touch on a few of them, but being able to lead legislation for Indiana and getting multiple bills passed bipartisan 100%, that's typically pretty difficult to do, but this is a program that's scalable and based on any community's resources is achievable to where everyone's seeing return on investments and wins. So, I mean, when, we're speaking about social determinants, 30% of the total healthcare spend nationally is on wasted, unnecessary, or duplicated services, uncoordinated care. And being one of the first, or the first fire department in the country to be able to document in our health system's EMR and coordinate those services directly with physicians and specialty care shows value. And when we first testified in the state sessions, we partnered with QSource, which is a quality assurance agency for CMS. And then they said, if every community in Indiana, all 92 separate counties, were able to put together a small proof of concept or a promising practice approach with a small pilot, we would be able to avoid about $200 million in healthcare charges. So that showed great impact. That allowed us the opportunity to go into other areas that are pretty non-traditional. I don't know of a lot of fire departments that are providing high-risk OB care in the home. It's one of the things that we're doing, working as physician extenders to improve Indiana's poor health outcomes, not only for babies reaching their first birthday, but for the mothers as well, when we're looking at maternal hemorrhage. And all the moms or women enrolled in our program are the highest of risk, whether we're looking at obesity, diabetes, hypertension, substance use disorders, depression. They're off the charts, and we're able to achieve great health outcomes in each one of these things. So, yeah, I mean, there's social value, there's public value, there's personalized value. And when you were talking about the triple aim, there's also values to health systems and our providers as well. Better coordinated care. In our area, we've seen a huge shift in retirements and providers moving out of our area. So a lot of my providers have a panel of over 5,000 patients, and that's unheard of in most areas. So to be able to provide that care in the home center and get them the right resources at the right time is very impactful, and it takes a huge load and shift off them. And we've done a lot to increase RVUs in that space too. We're able to make sure that those offices are maximizing CPT codes, utilizing us in the home too. So it's another way to demonstrate value. So each one of those mobile mat, first fire department in Indiana to provide mobile mat. So it's just so many wins. This is a project that adds such value to my day because it seems like all the non-traditional partners that we pull into scaling or creating our projects is just, it's just fantastic. I mean, I can't tell you how happy I am to deal with this compared to all the other stuff we have to deal with as a fire chief or anything else.
Thank you. You touched on a couple services. I'm wondering if you can just kind of share with the group all the services that your community paramedics provide.
Yeah, so right now we're currently operating 6 different projects. So we started off with heart failure, but what that did is quickly lead into chronic disease management. We were seeing high readmission rates, about 23.5% with heart failure. We were able to reduce that within 1 year by 90%. And we had 0 readmissions with anyone enrolled in our program over 2 years, 30-day readmissions. So success builds success. We were able to evolve into high-risk OB care, a project to help senior citizens age in place in the home through a falls prevention program, vaccine initiative. We were trying to reduce or improve vaccine rates of school-age kids. At the time of COVID, only about 19% of Indiana kids were fully immunized and ready for kindergarten, and only about 47 to 50% were immunized at 6th and 12th grade levels. So we were in the school providing those levels of care. We're standing up vaccine and COVID community projects as well. Mobile mat in the homes through our quick response team is another initiative. And we are partnering with United Healthcare for LTSS projects, so long-term systems and services to help our seniors age in place. And we're also doing 65 and over wellness visits to reduce the burden on our primary care physicians and better coordinating services, getting them into the office. We're doing these remotely the way we do a lot of our projects. So yeah, busy.
We had somebody ask in the chat box, can you share in more detail what your mobile mat includes?
Yeah, so we have multiple layers of it depending on what the patient wants to do. So we can do an abstinence-based program. We can do medication management. We offer faith services or Suboxone in the home. We manage that for up to 3 days, so nights and weekends, to where they can't get in to a physician's office, behavioral health office, or a provider that would prescribe in that area. In many areas, ER physicians will not do anything with the 72-hour rule. So our paramedics go through the MAT waiver training as physician oversight. We do the COWS assessments, all the coordination of care. We're allowed to break the glass in this space to make sure that services and oversight's in place, and then manage the care in the home, looking at all the social determinants that may be affecting their long-term recovery to make sure we put those systems and supports. We have peer recovery. The medication, the BUP, is actually on our trucks that we can deliver it immediately, working as that physician extender. So it's a huge win. It's a super simple project to put in place that has great benefit.
Another person added, can you share your protocols for Suboxone in the field?
Absolutely. I'll get those resources to you, and you can share them with anyone that's interested.
We appreciate that. We also had a question about the high-risk OB involvement. How much of that is telehealth versus coordinating transportation for the patient to their provider?
So it's very patient-centered with individualized care plans based on which trimester they're in and what their needs are. So for our moms that need to be on bed rest, that may be labs, that may be McKenna injections. We do have remote patient monitoring through telehealth that has Bluetooth scales, blood pressure cuffs, and blood sugar monitoring. And then we enter that information or labs right into Epic to be able to work as that physician extender. So it's very personalized. It may be different with SUD cases versus hypertension. But we have, through our projects, while we do have a lot of social issues that we work with, kind of like case management or anything else with our ACO partners, we do a lot of clinical care. We want to maximize our scope in the home, working as that physician extender. We provide transportation as well. Each one has a little bit different touch in our different services areas. We have paramedics that specialize and work with specific medical directors in each one of those individualized projects. So we're speaking the same language. those physicians are seeing the documentation in Epic the way they want to receive it. And each one just has a little bit of a twist to it.
Thank you. We've got another question about your billing. How does it work? And how are you being paid for those services?
That's the best thing. So I do not do the billing. Don't want to do the billing. That's one of the things I'm working with Indiana Medicaid on currently on their advisory committee. But it's our physician's office that would bill. So we don't bill for case management, any remote patient monitoring, complex care, transitional care, any of that. That goes right through our physician's office, even community healthcare worker reimbursement rates. I don't have to deal with that. Our hospital pays us a flat service fee. We do it kind of in a shared value approach as we've evolved it. So the city will pay for all fringe benefits, and the health system, our partner, pays for all operating costs and salaries.
We also got a request for your PMPs for OB, so I'll follow up with you on that one as well. Richard, could you share your services as well?
Yeah, our services, like I said, we do a lot of social determinants of health screenings and plugging people into social resources, but we do chronic disease management for the big disease processes like CHF, asthma, COPD. We do mobile urgent care is what we call it. So this is when the patient's physician refers that patient over to us. Mobile urgent care calls tend to be your asthma, COPD, your mild to moderate acuity patients, exacerbation of CHF, but also nausea, vomiting, diarrhea, where we'll go in and we'll deliver antiemetics and IV hydration. We do some chronic disease management where we're not using controlled substances for that. We're just using Toradol. And then we're looking at a MAT program. So Chief Miller, I might be reaching out to you to find out what you guys are doing over there. And one of the things that we're working on doing right now too is providing post-discharge follow-up for 7 and 30-day discharge patients from behavioral health facilities. In addition to that, we are working with some payers to go out into the field and administer injectable antipsychotic medications to patients that are not meeting their outpatient appointments. So there's a lot of things that are in the works right now too. This just tends to be the more you offer and the more success you see, the more requests come your way. So it's like there's so many opportunities that we're trying to focus on things that we know we can do a great job at and make the biggest impact at, but at the same time venture into other projects where we can just do a lot more good for the communities that we serve. When it comes to reimbursement on our end, we're reimbursed a couple of different ways. We bill the ACOs directly for at-risk populations for our services. And we also have contracts with specific payers to where when the physicians refer members of that payer to us, we bill the payers directly. And we're also working on a shared savings model with some of our customers as well.
We've got a question. So with Acadian being such a large organization, are the communities assigned or aligned with different hospitals based on the location? With the different areas that your organization is working in, do you align your community paramedicine with specific hospitals based on where they are?
Right now, we're not. We are working with we're working with a couple of large hospital systems in some of our markets right now, focusing specifically on their employees and their employees' dependents, providing mobile urgent care services to those. But our experience really has been that the hospitals, when it comes to starting like a hospital readmission reduction program, there has been less interest from the hospital systems in programs like that compared to ACOs that are fully at risk for a population of patients, and also with the payers. But we are in discussions right now to launch some programs with a couple of big hospital systems in the state.
Thank you. Do you use separate staff to do your programs, or do you use regular EMS staff? That is a chat question.
Yeah, we're making a transition right now. We were utilizing just a small, very small group of dedicated community paramedic staff to go out into the field and operate the program, and utilizing the supervisory staff from the EMS side of the business to provide coverage when we don't have a community paramedic that's readily available to take that call. However, our volume has grown to the point now to where we can justify hiring dedicated staff for all of our programs. So that's actually what I'm in the middle of doing right now, is hiring for programs here in Louisiana and also expansion of programs in Texas, which leads to another issue. The EMS staffing shortage. Y'all might have seen that on the national news just a couple of weeks ago. Before Christmas, they were talking about the national shortage of EMTs and paramedics. That's very real. You know, we're having a hard time staffing our ambulances, but then at the same time, we have a need for EMTs and paramedics to fill positions in this division of the company too. So what we're doing is we're looking at alternative models to where we can utilize licensed practical nurses or licensed vocational nurses as their scope of practice allows, to help us with those staffing challenges.
Thank you.
I'm going to piggyback on that. So we're seeing the exact same thing on the fire side. Paramedics are in high demand. We've had open positions for a long time, paying one of the higher salaries around our area, and still have a problem recruiting. We do use our community paramedics as a career extender for our firefighters that are looking at retiring, but we've had to do in the last few years, I've onboarded 2 RNs, one that used to run the nurse family partnership, kind of using them in a different role in a fire department, and then social workers as well. So we have 2 full-time social workers that work in our staff, kind of a co-responder program.
Thank you. Thinking about getting started with community paramedicine, what were some of those key stakeholders that were part of your planning, implementation, and outreach?
I'll go first, I guess. So first of all was finding somebody that was willing to give us the referrals of the patients, right? We knew that we had our data on the 911 side, right? So we knew who these frequent utilizers were, but then it came to, you know, okay, well, we can impact these people, but how do we impact all these other people too? How do we engage with the payers? Because we don't know what resources are available to these people, right? If they're covered, if they have coverage through Louisiana Medicaid or whatever state, any Medicaid system, you have different MCOs that are providing coverage, and each one of those companies offer different resources to their membership. So it was trying to get the attention of the payers to find out, to work with us and allow us access to their case management teams. So when we did find one of their members that had a specific need, we could put them in touch with the appropriate person within that organization that can connect them with the people that are going to actually provide the services for them, or get them the equipment that they need, or if they need just new steps built going up to the front porch of their house, things like that. So it was working with the payers to get their intent, to get their attention, to let them know, hey, this is what we're out in the field doing, and we need your help in order to make your members' lives a lot better. And at the end of the day, who's going to benefit the most? The member, but the payer is also going to benefit because we're reducing the spend for each one of those members. So I think that you know, reaching out to the payers and getting their attention and getting them to buy into the concept was a big hurdle at the very beginning.
Thank you. How about you, Paul? What were some of those key stakeholders involved in your planning, implementation, and outreach?
So we did a series of a lot of small, very deliberate meetings. Saw a lot of programs fail, specifically in the California area, never being able to offer an opportunity to get started. So the first place I went was to our state nursing association and met with the nursing president and kind of asked for permission in order to kind of do this. We wanted to make sure that they understood, we're not trying to duplicate services. We are not looking for scope creep or creating any other issues. Politically, I wanted to get it up front of it, which we were given the green light. We met with our health system CEO, CFO, and internally with our ACO manager, because a lot of what we were doing sounds a lot like we're trying to create our own ACO or our own health department. So we brought those community partners in and met with them one-on-one. And what we never wanted to do, obviously, I don't have an MBA. My background's not in healthcare administration. I didn't want to tell them how to do their job better or how to make it more profitable, or to tell my CFO how I'm going to save him money in a fee-for-service world. What we did is offered opportunities and let them kind of evolve to and see where we could provide benefit and provide better outcomes. And then we came together as a larger stakeholder committee through the clinical operations committee, which involved primary care, emergency care, pharmacy, and we talked about all the things that were affecting that specific health system separately and things we needed to be aware of to maximize reimbursement, reduce penalties, or maximize incentivized payments together. And then we started each one of these systems. But having that internal champion and making sure that those fire departments aren't going and telling the CFO how to run their health system is a big key for success.
And just to piggyback on what Chief Miller said too about, us not trying to duplicate services, that's huge. That was one of the things initially when we were going and we were talking to hospital system leadership and payers and whatnot, they were like, well, this sounds like home health nursing. Why are you guys getting into the home health? And I was like, no, that's not what this is. This is about identifying gaps in an existing system and utilizing resources that are in the community and available to you to fill those gaps. That's exactly what it is. We're not looking to duplicate services, and quite the contrary. We're not competing with home health nursing. We're not competing with hospice. We're not competing with anybody. We're a partner. So if you have a gap in your system and you have a need that needs to be met that you don't have the resources to provide a solution for, we're here and we're willing to help.
So that's an excellent point. And when we first started, about 90% of our referrals came from home health. They had already completed their project. They knew they still needed additional touches. They obviously have a limited time that they're allowed to bill for. They still needed additional care, so they referred to us. We made sure part of our clinical ride-along process paired us with home health and hospice, so we knew how to identify when we were needing to refer to home health instead of us providing the care. And each one of our patients that's referred to our project come from typically an ACO nurse in the primary care or specialty office or discharge planning. So it's good coordination of services.
Thank you. This one's for Chief Miller in the chat box. With your service area size, how many visits or calls are you averaging weekly? And with how many per paramedic or EMT?
So each one of my 13 providers in the field probably has a panel of 15 to 20 patients. Each one of those visits, it's at least one visit, either remotely by phone or in person each week. It's tapered. Each project's different, whether chronic disease looks nothing like OB, the social workers could spend all day with one patient when they're looking at finding facilities. We're not going to the ER. So it's different, but I would say with time off and everything, travel time, we're in the thousands of visits. The high risk OB is a lot more attention. My busiest paramedic in that space probably has about 2,000 touches alone per year.
Thank you. This is for either one of you. Knowing what you know now, what would have been helpful to know when you got started?
Go
Any good
slow.
lessons learned?
When you were speaking about how everyone wants more and that opportunity creates more success and more pathways to deliver more care, you have to be very deliberate. It is very easy to think that you are going to save the world immediately and everyone's going to see immediate value throughout this health system and community. And I would say start any project small enough that you can achieve success. You never want to set yourself up for failure because you can't recoup or you can't rebound from a failure. That's all they're going to remember. So with your healthcare leadership team, stand up a small project that you are going to be successful in, and then scale it and grow from there.
And part of being able to demonstrate that success is having the data to back it up. So that was something that we still continue to struggle with today, is trying to improve our data collection and be able to paint that picture and clearly show the ROI to our partners and our customers. But, you know, like Chief said, you know, it's pick one program, but be very specific on what success looks like. Because if your target is too big, then you're not going to be as successful as you could be, as opposed to starting very small, very deliberate, and then don't try to do anything else until you know that you're doing that right.
And I would say, so I travel quite a bit, meeting with other health systems and looking at, you know, trying to help them be more successful in initiating a project. And we pull together meetings, and the larger meeting they'll have with more entities, they typically will start small, and then there's a lot of add-ons. Everybody wants one more thing added on to the project. And typically I see that stifling them moving forward, and they never get off the ground floor. So I cannot tell you how many different health systems I have met with and seen that happen. But the successful ones continue to start small and then grow.
Thank you. And I've appreciated the chat box being so active today. I'm glad that you guys are engaging with our speakers today. They are also going to join us next Thursday, same date and time. But I do want to go back to sharing screen one more time to highlight, if I can not freeze up here, our framework and components for the Delta Region Community Health System Development Program, Community Paramedicine Technical Assistance. Each of these components are critical to successful CP models as identified through EMS assessments, literature reviews, and best practices. The technical assistance framework that we will be providing will be expanded upon in our next webinar next week. And we will incorporate center-known processes, tools, resources, and work with key center and consultant subject matter experts. This will help guide our healthcare organizations, our local providers, EMS, and community partners through planning, preparing for, implementing, and sustaining a community paramedicine model in their communities. And we will walk through each component of this framework next week on our follow-up webinar. I do want to open it up further for some additional questions from our audience. Do we have any more questions that we would like to ask Richard Bell or Paul Miller today? And you can feel free to unmute yourself or utilize the chat box.
I just want to say thank you all very much for spending the day with us and talking to us about y'all's programs. It was really beneficial.
Thank you. Happy to do it. To me, that's one of the coolest parts about this job now is being able to share what we've done and learn from other people, like just sitting here like you guys listening to Chief Miller tell his story. Well, I learned a lot from him today too. Just knowing what other people are doing across the country. We all benefit, from everybody's individual successes. So I appreciate the opportunity to participate in these types of events, just to share, what it is we're trying to do for the communities that we're serving.
What recommendations would you give our listeners today if they're considering implementing community paramedicine in their communities?
I would say that you need to reach out to the stakeholders in your community. Start with whoever the EMS provider is in the community, whether it's fire-based, whether it's third service, municipal EMS, private EMS, whatever the case may be. Because I would venture to say that you might be surprised that the leadership for those agencies are already talking about this. So reach out to your EMS agencies and just start that dialogue with them.
Absolutely. Identifying early on your internal and external stakeholders who can champion this. One of the other tips I would probably give too is working with your Medicaid partners and your state departments of health and trying to implement a promising practice or an approach with somebody else's money. I mean, it is very difficult. I mean, all of us are on limited budgets. And if this is a true shared value, everyone's going to demonstrate different return on investments and wins. So if we can bring those together early on and get more, I mean, research is very, very expensive. I partner with all of our state institutions in different projects, making sure we have a subject matter expert to tell that story, to speak to their colleagues, to assist in building what this should be for each individual state or community, because it looks so much differently based on resources. So let's come together early on, build this, scale this, and then make sure it's financially sustainable moving forward.
We have a question in the chat box that I think we're going to go into a little bit greater detail on our next webinar next Thursday. But any key lessons learned or pro tips regarding recruitment and retention strategies for community paramedic workforce development in rural?
It's expensive and ongoing. We're dealing with this right now. I've met with the mayor. We've got follow-up meetings with the council. It's ongoing. Every community is seeing it. I know we're really seeing it with pediatricians, primary care, even in the ER, let alone the nursing and paramedic shortages. So it's something that everyone is facing, and it's getting difficult. I don't have a good quick fix. If I was, I probably wouldn't have to be a fire chief anymore. I'd just go into consulting.
You'd be very successful if you had that figured out, Chief, because I guarantee you we would hire you if you had the answer. But one of the things that we're focusing on right now, and I've been trying to express the importance of this to our leadership, is being able to illustrate that this is a different career path for a paramedic that comes to work for our organization. We have multiple, Acadians is a very diverse company, so we have multiple career pathways for people. So this is just another career pathway for an EMT, an AEMT, or a paramedic, to where if they want to continue to do patient care and they want to make a difference, they want to still be out in the community caring for people, this is something that they can do with a reduced stress level as opposed to staffing a 911 unit. And hopefully we can retain them for longer, because the turnover rate is, you know, the lifespan of a paramedic in a 911 system, especially a very busy 911 system, is very short.
I will say, all the paramedics I have working in this space have moved off a busy 911 fire truck. None of them were primarily on the ambulance for a number of years, but their job satisfaction moving from either being a fire officer or a firefighter has gone through the roof. I've seen zero turnover. And I've had my employees going back since 2017.
Mm-hmm. So that could potentially attract. That's the direction that I'm going to, is trying to be able to illustrate that career path for somebody coming into the company, so they would prefer to come to work for us, because they know that 3 years down the road they could be doing this full time as opposed to working a 911 unit if they choose to do so. Another thing that we're looking at is creating a dual role, to where we can bring in an EMT or a paramedic to work a specific project, a community paramedicine project, but they would alternate between working on an ambulance and working in this department. So it's like one pay period they would work in ground operations, staffing an ambulance, and the next pay period they would rotate into our CP program and staff that. That way we could hopefully attract people to come to work for us as opposed to somewhere else.
Professional inclusion is really big. My paramedics love working one-on-one with the nurses and physicians in this space.
Yeah, they build an amazing relationship with the providers.
Well, thank you both. I am adding my contact information to the chat box. If anybody who's listening thinks of some additional questions that they want us to address next week during our webinar, after you've had some time to reflect on the content today. I do want to remind you, next week is webinar 2, same time, same day of the week. We are going to go into greater detail on the framework that was shown, and our panelists will be providing some insight on those key components that we need everybody to consider as they are going to be moving forward with the technical assistance through the Delta program. We are also going to share how you can apply for technical assistance in this area and talk through any additional questions that you might have. Alyssa, do you have anything that you would like to add?
Thanks, Karen. Nope, those were my notes that you closed with. So I look forward to having everyone back that wants to learn more about this technical assistance opportunity.
Thank you all for joining us today, for asking great questions, and thank you, Richard and Paul, for sharing your insight with us today.
Thank you.